Various examples of techniques to lateralize massive retracted rotator cuff tears are shown. In this first example, left shoulder in the beach chair position, we can see a very retracted rotator cuff tendon tear that's immobile and not lateralizable back to the anatomic medial margin of the footprint. In this example, a capsule release is shown, and its ability to lateralize the rotator cuff to some extent is demonstrated. One can see the glenoid to the left, the posterior capsule to the right, and we can see a 270-degree capsule release. When we now pull on this same rotator cuff tear, we can see that there's not dramatic lateralizability, but it is clearly significantly more lateralizable for a centimeter or more than it was before that capsule release was performed. In a second example, left shoulder beach chair position, again we can see a very retracted rotator cuff tendon tear. In this example, only an anterior interval slide is carried out. When that anterior interval slide is completed as shown, then we can lateralize the rotator cuff back to a mid or even lateral portion of the anatomic footprint. This allows the authors to repair this rotator cuff tear in a slightly medialized position, but a complete repair nonetheless. In this third example, left shoulder beach chair position, we can see again a very retracted tear, and in this particular example, a posterior interval slide is carried out. This posterior interval slide is continued all the way to the scapular spine, and after that posterior interval slide is completed, note that we can lateralize this rotator cuff tear that seemed unrepairable back to essentially the most lateral aspect of the anatomic footprint and achieve a complete repair. In this last example, we're going to combine all of these elements: a beach chair position, very retracted rotator cuff tear, and a right shoulder that's not lateralizable back to the most medial border of the anatomic footprint. But when a capsular release is completed, combined with an anterior interval slide, then we can now see that this very retracted rotator cuff tear is now easily lateralizable back to the most lateral margin of the anatomic footprint. And that's true of all the different components of the rotator cuff tear as shown here. The 50-yard line view for the arthroscope is promoted by the authors because it allows us to see the underlying superior capsule and appropriately incorporate that capsule into our rotator cuff repairs. 2 double-loaded medial row anchors have been placed, and sutures are carefully passed at the appropriate position in the cuff so that when these sutures are tied, there's not an over-lateralization of the rotator cuff repair. These sutures have now been tied, and note that the remaining more lateral cuff, when reduced with this grasper, is reduced to a more appropriate anatomic footprint and is not overly lateralized. In this particular example, again, initially it seemed irreparable, but now is intimately repairable. A double row transosseous equivalent technique is used for a near anatomic repair of this large retracted rotator cuff tendon tear using interval slides and capsular releases.